Eddie Kirby with Kirby Plastic Surgery, double board certified in plastic and hand surgery. Today's patient story, the Footballer'S Fingerless 4th of July. So my patient is a 17-year-old high school college-bound football athlete on scholarships to college for this. And unfortunately on July 4th was playing with some extremely powerful fireworks, and unfortunately one detonated inside his right hand. Now he was taken to a local trauma center where fortunately his injuries to the face, the chest, and his left hand were superficial and treated with local wound care. But as you can see here, the injury to his right hand was absolutely devastating. You can see here in this image his right forearm and his right thumb for orientation. Again, a dorsal view of his right hand after that injury. So x-rays from that injury demonstrate basically a garbled mess of dislocated metacarpals, of both phalanges, complete disarray of the hand and palm. And so he remained at the trauma center for about 12 days and underwent 5 debridement procedures. And so on July 16th, I was contacted about accepting this patient for definitive management at our Art Microsurgery and Nerve Center at San Jose, and of course accepted the patient for transfer under my care. So here he is at the time of his first debridement with me. Immediately upon accepting him, I got him to the operating room. And what you can appreciate is that the 2nd through 5th fingers have been amputated. There's a large soft tissue defect here with exposed bone, tendons, muscle, and hardware. But as soon as I remove the dressing, it becomes abundantly clear that this is floridly infected. There's actually pus emanating from the wrist. The wound is foul-smelling, and there is necrotic interosseous muscles, metacarpal bones, and tendons. Thereby, the hardware is also infected. And so, unfortunately, I'm really back at square one with this patient in terms of upper extremity trauma management, despite him having undergone 5 debridements. And this is the case because one of the most essential and basic principles in the management of any hand trauma is complete removal of any non-viable tissues in order to get an uninfected, clean wound so that you can start to think about closure. Additional views here of the palm that you can appreciate the degree of infection and necrotic tissue. So here he is after that first debridement. Things are looking a little bit better. I've had to shorten those metacarpals, remove the hardware, get all the dead tissue out, looking far healthier, and perform provisional fixation with K-wires as shown. Note in this view, you can see the degree of palmar degloving that has taken place with this injury. Now for his second debridement, just a few days later, unfortunately, he's growing Enterobacter cloacae complex organisms from that base of that wound from the first debridement. And so this is a pretty infected, pretty highly virulent and bad infection of the hand that we have to clear. And at this second debridement, it's very clear that there's ongoing necrosis, there's ongoing infection, despite being very aggressive with that first debridement. And so once again, attempts are made to try to salvage those metacarpals as much as possible because I want to be able to provide a bony framework to allow for palmar stability and the potential to even add toes with free toe transfers if the patient should decide to go that way. However, some important points here. I mean, these metacarpals are bathing in infection. They're not bleeding. They're stripped largely of virtually all of their periosteum, and they're not protected by soft tissue coverage. And so that makes it very difficult, if not impossible, to salvage these metacarpals. Also note in the image on the right that I've pinned the thumb in a palmar abducted position as shown. Also performed a carpal tunnel release as shown here. So at this point, I'm having lengthy, frank, and candid conversations with the patient and his mother about what the best course of action here is. These debridement cases give you a good sense of where the patient is and where they're going and what's possible in terms of outcomes. And so after several heart-to-heart conversations, the patient and his mother repeatedly expressed their kind of unwavering commitment to get him back to football. That's really his life. That's his plan for a career. And so we discussed transradial amputation with TMR, RPNI, advanced prosthetics. We discussed even amputation and hand transplantation as an option, possibility. And we discussed conventional reconstruction, where we would preserve his thumb and then optimize his thumb, recognizing that he's lost a lot of the intrinsic musculature of the thumb. It's insensate on the palmar side. He has sensation on the dorsal side. and that his function may be poor, and he may go on to require several subsequent procedures, free fibula, toe transfers, and so forth. So after all these lengthy conversations, the patient decided they and his mother, they wanted to proceed with conventional reconstruction to optimize his existing hand. And so we proceeded as such. So I took him for his third and final debridement, as shown here, and at this point, it became abundantly clear that salvage of these metacarpals was just not going to be possible. I mean, you can see in that image on the right how unstable they are. They're only hanging on by a few soft tissue attachments. And also, these are consistently growing Enterobacter cloaca complex despite multiple debridements. They're not bleeding and so forth. So I've removed the central two, preserving the second and fourth at this point, and performed provisional fixation as shown here. So a few days later, I take him back for definitive flap coverage of his wound. I decided to use an ALT flap, a true workhorse, taken from the right thigh as shown here. Here's his right thigh and markings planned for the ALT free flap. Here's the dissection. You can see the skin paddle there. You can see the single perforator, which fortunately was the septocutaneous perforator here, and the nerve to vastus lateralis, which is separated and protected and preserved inside the patient. And here's that just further dissected out, really showing his anatomy very nicely, and a video documenting this.
After evaluation, we've completely separated the nerve to the vastus lateralis, both proximally and distally around the perforator, as you can see there. And a single perforator, fairly centrally located right there. Good pedicle length here. Going into the flap. There's the flap itself.
Now, it's really important to try and provide sensation in these flaps. And given that his volar sensory branch of his ulnar nerve isn't doing anything, I found a nerve as shown here in the flap that I would then coapt to the volar sensory branch of the ulnar nerve to give him some feeling in the flap once it's transplanted to the hand. This is just showing that anatomy in surgery of that, and here's a video I took of this.
For evaluation, the ALT has been isolated on a single perforator, and there's a nice sensory nerve branch in the superior aspect. It's going to innervate fairly centrally in the flap, so we're going to innervate this to neurotize the flap to the ulnar nerve.
I then go to the recipient side here and dissect out the ulnar artery and ulnar nerve in preparation for transplantation. You can see the ulnar nerve and ulnar artery and veins there. Now here are some critical final decisions before flap transfer. I've tried to hold on to these metacarpals as much as possible. Cultures have repeatedly been positive with Enterobacter cloacae from the basis of these despite multiple washouts. They're hanging on by a few soft tissue attachments. They're not bleeding. They have no periosteum. So leaving these behind could run the risk of infection, osteomyelitis, loss of the flap, need for amputation. Big deal. However, on the other hand, not having a single bony post against which his thumb could potentially pinch or grasp simple objects would result in a significant loss of function for him. So I decided to compromise. I removed the fifth metacarpal stump and I preserved that second metacarpal. And I would use the ALT to essentially wrap around and envelop this basically devitalized second metacarpal stump to try and revascularize it. And it actually worked, which is just incredible. So here's the flap. It's been transplanted up. The microsurgery is performed at where it's shown here. Ulnar artery and veins are used to power the flap. From the arteriovenous standpoint, the volar sensory branch of the ulnar nerve is cooperating to that sensory nerve in the flap. You can see the flap there with good color. And here's the flap around that second metacarpal folded on itself, completely circumferentially enveloping that second metacarpal to try to preserve it and revascularize it so that he can have a bony post as shown there. So how did he do after all of this? Well, here he is on post-op day 10 in the hospital. Fortunately, flap did beautifully, good viability as shown here. And here he is in the clinic at 2 months post-op. So I'm very pleased with his progress at this point. He's using the hand. He's coming to terms with it. He's not denying the hand anymore. He's coming to terms with it and actually using it to grasp simple objects.
Approximately two months out, ALT flap, preserve the second metacarpal here. Let's see what you got in terms of your wrist function. Can you bend, rest, extend your wrist? Best you can. Okay, good. And show me what you have in terms of your thumb function. Very good. Okay, excellent.
So he's doing well, and he's using the hand, which is exciting. And he's not interested in additional procedures like second toe transfer. He's coming to terms with this and happy with this. However, there are some issues that need to be addressed in a secondary surgery. The most important here is this painful median nerve neuroma he's developed, where he's exquisitely tender at that location where I've marked the X, and that's of course limiting his hand function. He's also got MP joint tightness and stiffness. He's got a lack of sensation in the radial and ulnar digital nerves of the thumb, which need to be repaired. So I took him back for an additional surgery to address each of these issues. Here he is in the preoperative area before taking him back, illustrating this painful neuroma.
He's got a fungal, is it tender? Yeah, very tender right there, fungal neuroma that we're going to treat.
So you can appreciate how tender he is there. So I took him to the OR and opened up. You can appreciate a large median nerve neuroma right there, right where the X was as anticipated. And once I've got everything dissected out, this is what it looks like. You can see that median nerve neuroma there, and you can appreciate the avulsed radial and ulnar digital nerves of the thumb. Note also the ulnar digital artery of the thumb there and the FPL flexor tendon, which are preserved. So the way in which I approached this was I would use an allograft reconstruction to link these two, which is basically the original branch, to the radial digital nerve. The ulnar digital nerve was a lot larger, and so I would split that central median nerve neuroma, diverting a lot of axons to that side, trying to restore sensation here, which is critical for pinch. So I used a very large allograft, and the residual radial half of that median nerve neuroma and that additional, probably third web space branch of the median nerve on the far left would be used for neuroma prevention. And so what I used here was the Allay hydrogel nerve cap to both treat his active median nerve neuroma as well as prevent formation of another neuroma, which is shown here. So you can see a very large allograft used for that ulnar digital nerve, smaller one for the radial digital nerve, and nice hydrogel nerve caps treating that painful neuroma and preventing formation of an additional neuroma. So here he is on the table at the end of that procedure. And so he went on actually to recover beautifully from this. He has no signs of neuroma pain anymore and no signs of recurrent neuroma. And kind of as an update, his mother has since informed me that he's back to playing football, and he's using this padded orthotic to get him back on the field. And his mom sent me this video. So pleased to see him get back and obviously performing very well in football. So I hope you enjoyed this patient story of the Footballer'S Fingerless 4th of July. As always, make sure your surgeon's board certified. Ask for pre-op and post-op pics. We'll see you for the next patient story.